All right, we're going to talk about GI, and let's talk about unintended consequences. So we look at this sign and kind of think about it. It's kind of funny when you look at it. Somebody really wasn't thinking when they put the sign up, did they? Massive meat sale. It could be interpreted in many different ways. And we're going to talk about unintended consequences. And in this, we're going to help you rock the boards. We're going to help you save lives and take care of your patients. Let's talk about a simple case. Is young children getting hepatitis A from eating raspberries. And you're like, what? What is going on for this? So let's talk about the unintended consequences of policies that may happen. So in Latin America, the owners of these farms that were growing these raspberries, they wanted their workers to be more efficient. So what they said to them is they said, we're going to change the way we're paying you. Instead of paying you per day, we'll pay you on the weight of the raspberries you pick. So human nature is what's going on is what would you do is they decided we need to get more weight in there. So they poop in the containers that the raspberries were being put in that would increase the weight. Unfortunately, their poop contained hepatitis A and the young children were getting contaminations from this. So this is the unintended consequences. Like this sign, I don't think that people put the sign up to think about, there could be other things this sign could be interpreted as, so the unintended consequences. Now let's get back to the GI. All right, in the United States, diarrhea leads to a substantial amount of hospitalizations. Estimated around 1.8 million hospitalizations per year for GI. Now let's talk about this gut biome. We kind of touched about it briefly before. Is the human gut contains roughly 100 to 600 million neurons. These neurons make up the enteric nervous system. This is actually considered the second brain. The human brain contains about 86 billion neurons, so it's not as much as the human brain, but it still has a lot of neurons. Now, we talked before about the gut biome. Let's go with another example. A lady was being treated for C. diff, and she had real tough problems. So what they were doing is they were trying a fecal transplant. And they tried one from one daughter who was normal weight. It didn't work. It didn't work, the fecal transplant. So then they said, let's try another one from your other daughter. For whatever reason, they wanted to use the family. So they did a fecal transplant from the other daughter. The other daughter happened to be obese. What happened is the patient who was not obese became obese. These are the things that we need to learn more about is this gut biome, is how it can change so many things in our life. Is obesity secondary to our gut biome? Is that why the Western civilization is having more obesity? Because the fact is that our diet is leading to us having certain growths of certain bacterium that are causing us to be obese. There was a landmark study many years ago is that there are certain people that produce a TMAO from digestion of beef products. These products cause them to have increased risk for coronary artery disease and MIs. This kind of was discussed and it kind of went under the carpet because the gut biome is so complicated. And then there's things that you can buy in the market, prebiotics, probiotics. We really don't know enough to say to prescribe these. And in fact, we can cause harm. In someone who has C. diff, it's recommended to avoid those because remember those walls of the intestine are inflamed, and the good bacteria, the bacteria that normally is our friend, can turn into our foe inside of our body if it senses weakness. So there's still a lot we don't know. In the gut microbiome, there is so much for us to learn, and we know basically nothing. All right, this is a case, and this is another tribute patient. This is a 37-year-old programmer with no past medical history. He was a programmer, great programmer. He got laid off. He got laid off, and he was depressed because he was a great programmer. The company he was working for had financial problems, and they had to lay him off. He drank too much for 6 months after he lost his job. Then he comes in for complaints of pancreatitis. So let's talk about approximately 10% of Americans age 12 or older, 12, have an alcohol use disorder. Now we used to use alcoholism, but alcohol use disorder is now considered the correct terminology. So 10% is roughly 28 to 29 million people. If you look at the census data from 2023 to 24, These patients are going to be walking through your offices. They're going to be on your wards. They're going to be in your ICUs. So take a look at this. I want you to get used to looking at images because they're putting them up more on boards, but also I want you to be able to start seeing things. See this right here? Let's go right here. Let's get a beautiful drawing right here. This is our pancreas. See where it kind of looks, we're going to use the word ganky. We're not so clean. I want you to start looking at your images and start seeing the differences between normal and abnormal. This gentleman had pancreatitis, this programmer. 80% of pancreatitis in the US is either caused by alcohol or gallstones. Stones are increasing due to increasing levels of obesity. Higher cholesterol means more stones. Also, alcohol consumption surprisingly is being lowered in the US. We're drinking less. We did drink more during the pandemic. Post-pandemic, it appears that people are drinking less. Let's go back to that real quick. Acute pancreatitis diagnosis requires two of the following. Acute onset of upper abdominal pain. This is consistent pain consistent with pancreatitis, can be in the abdomen, radiating to the back. Have an elevated serum amylase or lipase that is 3 times higher upper limit of normal. Lipase is preferred due to tests due to longer half-life and more sensitive and specific for pancreatitis. Amylase can be higher in other diseases such as peptic ulcer disease, can be even higher in DKA, acute cholecystitis. Findings on cross-sectional imaging, CTA, MRI, ultrasounds. Let's go back to this again. 2 out of 4. You need to have 2 out of 4. Abdominal pain that's going to be consistent with pancreatitis. Like if it's the right upper quadrant and you have a positive Murphy sign, that's going to be acute cholecystitis. So abdominal pain, where say in the abdomen, radiating to the back, that's going to be consistent with pancreatitis. Elevated serum amylase or lipase, that's 2 to 3 times higher than normal. And then we're having what? Findings on imaging of having findings on imaging. So 2 out of these 3. Acute pancreatitis causes prolonged alcohol use. 4 to 5 drinks daily for greater than 5 years can be used. It doesn't have to be perfectly that way. It can be less drinks. Like in our gentleman was less, he was drinking more, but he's drinking over a shorter period of time. Biliary tract disease, trauma, beginning something getting punched in the pancreas is, we can have this question because 2 MMA fighters, one gets a gut shot and develops pancreatitis or symptoms of pancreatitis. Post-ERCP, so ERCP, you can have a propensity for getting pancreatitis post. That's why they give indomethacin. Prior to doing ERCP, it reduces the risk of pancreatitis. Autoimmune, hypertriglyceridemia. Now, I know your textbooks are going to say greater than 500. The true answer is greater than 1,000. We'll speak how they could be correct at 500. And then vasculitis can cause this. Vasculitis can cause anything. There are also those other things, could be uremia, hypercalcemia, cystic fibrosis, pancreatic cancer. Drugs such as valproic acid. ACE inhibitors can also, azathioprine, mesethylamine, infections such as mumps, Epstein-Barr virus, which does everything and is a horrible disease, and it probably leads to dementia. We're learning more and more how this is a horrible virus that does so many things to our body. CMV, indications for doing a CT scan if the diagnosis is uncertain, and an inflamed pancreas noted on CT confirms the diagnosis. All right, so let's go back to talk about hypertriglyceridemia. So the older textbooks had, they would say greater than 500. Now it's changed to 1,000. The 1,000 is being more correct. But how could those people be right when they said 500? Is they're saying your baseline is 500, but there's also, and there's a wonderful study that showed how much your triglycerides increase from certain meals. Say you ate a big pint of ice cream, a certain brand that is very rich, and you eat it. You can get a flood of triglycerides. Now, what if you're constantly eating throughout the day, so that way your baseline may be 500, but you're constantly having exposure greater than 1,000 because you're eating high triglyceride meals constantly throughout the day. The meals have high triglycerides and it can cause you to have pancreatitis from there. So this is where 500 may work. The correct answer is going to be greater than 1,000, but just giving you kind of what they were thinking when they said that 500. How much fluid to give? This has always been a question in pancreatitis because one of the treatments is giving fluid. That's probably the mainstay of treatment. Going MPO or holding oral food products is kind of going away. In severe pancreatitis, of course, when you have nausea and vomiting, yes, you want a whole food, but advancing where you're giving post-duodenal feeding as soon as possible is pretty much becoming the standard of care. So the old maxim of not eating or holding food is going away. Now, it used to be is extreme aggressive resuscitation. Extreme aggressive, and we're causing harm with this, and we'll give this in this case, is extreme because too much fluids can be harmful. And in this study, as we discussed, is doing moderate versus aggressive resuscitation. Remember, we think the pancreas is inflamed, and we're giving fluids to kind of put out the fire. People are using the Parkland formula, and you're getting massive amounts, some cases getting at least 17 liters in a 24-hour period. There was flimsy evidence on this. And so now we've had a study, this was in Spain with 249 patients. We did aggressive with 20 milliliters per kilogram over 2 hours, then using 3 milliliters per kilogram over multiple hours. So basically these patients were giving about 7 liters. And then in the moderate, they only used 10. Still, these are all less than the 30. Did you think about that? And these patients roughly got about between 3,000 to 4,000. So the evaluation for fluid overload over 72 hours. So in the high end, at the end of the day, they got about 7 to 8 liters. In the low end, they got about 4 to 5 liters. So they had to halt the study early. I hate when they halt the studies early, but they have to protect the patients in the study. You'd like to see them get the full data set. They halted the study early because they have fluid overloaded. So the fluid overload in the aggressive therapy was in 20% of patients versus 6% in the moderate group. This is an open label study. It's hard to fake having fluids going into the patient's body, but the conservative approach was better for the patients. So conservative was better. These high doses of fluid, back in the days, people getting up to 17 liters based off the Parkland formula. And then using even this study where patients were given about 7 to 8 liters versus 4 to 5 liters, the less aggressive fluid resuscitation was better. Poor prognosis signs in acute pancreatitis. Here we go, look at these. These are just basic things that you should know right away. Systolic blood pressure less than 90. Remember, they're not perfusing, heart rate greater than 130 beats per minute. Urine output, that horrible thing that they call you on that urine output, so important. Less than 50 milliliters an hour, or increasing BUN and creatinine, shows that they're having an AKI, correct? Presence of two of the following inflammatory response syndrome, greater or equal to 2 of the following, is going to be temperature below 36 or above 38, and having a pulse greater than 90 beats per minute, and respiratory rate greater than 20. Pancreatitis necrosis seen on CT imaging. BMI greater than 30 or age greater than equal to 60 years. Hematocrit greater than 77. This is showing their heme concentrated, and C-reactive protein greater than 150. They're showing their inflammation. Now, you can use these different things. You can also use the Apache score. The Apache 2 score is a severity of disease classification. It's used in critical care to predict the risk of death in hospitalized patients. There's usually 12 measurements. And you actually can calculate this pretty easy online. Everything from age, respiratory rates, sodium levels, potassium level, and you have a score from 0 to 71. The higher the score indicates a greater severity of illness. How about instead of using this, we do something real simple. And I want you to get used to this as a provider, is to do something as simple as counting organ systems. Greater than 3 organ systems down means you have less likely ability for this patient to leave the hospital intact. So one system, say this patient had pancreatitis, so it's GI. Say they also had pneumonia with this, so we'll say 2. They also, so infectious, we'll say respiratory, they have pneumonia. Also 2 is they become altered. So we have 3 systems. Altered mental status, so CNS, GI, and then respiratory. They have pneumonia requiring oxygen where they don't normally require. Then we add the fourth one, say they have an AKI. So that's why kidney function is so important. We need to manage our kidneys well as our patients get sick. We need to always manage the kidneys, but as they get sick, it's so important because that could be the third, fourth system that tips them over, where these patients go from maybe getting out alive to passing in the hospital. These are things I want you to think about, is how many systems this patient has affected. Sometimes you have patients that come in and every system is affected, and they're less likely to leave the hospital alive. Now, are they perfect? No. You can have patients that have everything wrong. They can physically leave the hospital alive. Are they doing well in life? No, but they can leave the hospital alive at that time. And so a PACHI-2 score greater than 8 would be a poor signs, poor prognosis in acute pancreatitis. Management of acute pancreatitis. All patients should undergo either a transabdominal ultrasound for evaluation of biliary pancreatitis, if unclear, MRI or endoscopic ultrasound. Moderate fluid resuscitation, we talked about this, not doing these mass amounts. Remember, still less than that 30 milliliters per kilogram. It's 10 milliliters per kilogram, then 1.5 milliliters an hour per kilogram per hour. Initial bolus is the patient has evidence of hypovolemia. See right here, remember how this has changed? Early oral feeding with a low-fat diet with mild acute pancreatitis. This is mild within 24 to 48. Before was no feeding whatsoever. Infected pancreatitis and necrosis. Getting a fine needle aspiration should not be performed. You're going to have trouble getting people to do these nowadays because you can go from bad to worse with this. Anytime the pancreas is touched, I just want you to think it's a bad thing. Even with a fine needle or surgery, the pancreas is a very delicate organ as far as once it gets touched with either a needle or surgery. Prophylactic antibiotics should not be given to patients with severe pancreatitis. As we're going through things, I'm trying to give you as many images as I can so that way you can start seeing abnormal and compare it to the normal. Right here is a pseudocyst. A pancreatic pseudocyst is a localized fluid collection in or around the pancreas that lacks an epithelial lining. It can be surrounded by granulation tissue. Usually contain amylase or another pancreatic enzyme and are connected with the duct system through the pancreatic parenchyma. Old teaching is that cysts more than 6 centimeters in diameter, greater than 6 weeks or longer, it should be drained. This is changing. Remember, less likely to touch the pancreas nowadays because we find we can cause harm. All right, so this programmer who unfortunately has drank too much alcohol, who had pancreatitis, with no past medical history. This is sad. He stops peeing. Why did this happen? Well, this is back in the old school days where we gave him a lot of fluid. And what did he get? Stop peeing. So he had abdominal compartment syndrome. So how do we check for abdominal compartment syndrome? So I want you to think right here is your abdomen. And if it gets distended, think of it as a tourniquet. Now, what's located in your abdomen? Your kidneys. Your kidneys are going to be the first sign of this. Can you get abdominal compartment syndrome so then the organs themselves can die? Yes, you can. But you can also get it's going to be the first signs. It's going to be decreased urine output. Remember that urine output, it comes to haunt us all the time. So when our nurse providers give us information about urine output, instead of cursing them, we need to thank them that they're giving us this information because it's an early sign that the patient is getting worse. So in this case, this gentleman stopped peeing. He had no kidney injury before. His creatinine has come up now. So how do we check for abdominal pressure? We put a bladder Foley, a specialized catheter that measures the abdominal pressure. If it's greater than 20, we have to consider that they have abdominal compartment syndrome. And then the first things you're going to need to do is you have to get a surgery evaluation. They may ask you to, if the patient's on the ventilator, that the patient gets paralyzed. More than likely, the patient's going to be on the ventilator, and they're going to evaluate for abdominal compartment syndrome. So complications is that fluid collections can arise from the pancreatic duct disruption and cause pancreatic fluid collections, cause abdominal compartment syndrome. So how is it treated? It's a surgical treatment. First, you can try paralyzing the patient and trying to fix what you can to see if the pressures will come down. The true treatment is a cut. So in this gentleman, when they cut him, the anesthesiologist was telling me is that you could hear it on the other side of the surgical table. Is he could hear when they cut, and usually cut from the xiphoid down to the pubic process. And in him, you could hear the hissing because the pressure, and then the organs just popped out because they were under so much pressure. So then what you do is you don't have a closure. You're going to put over, they have different types of dressing nowadays that you put, so to kind of close but not officially close up the abdomen, get the tissue to relax, and then when that happens, you can close it up later. Suddenly, difficulty with oxygenation on the vent. So this patient too, during all this, he was intubated earlier, and then we had trouble with oxygenating him. So he got worse, he got intubated, and then he's noted for compartment syndrome because he stopped peeing. Then we're having trouble on the vent with ventilation. Remember, we're crossing over a whole bunch of things because these patients are just not multiple choice questions. We're gathering different parts and we're teaching you in a systemic way, so that way you're going to be able to do well on your boards and you'll be able to take care of really sick patients. So remember, this is a guy with no past medical history, started drinking, and then this is what happens. This is what he shows on his chest x-ray. What is this? This is consistent with ARDS, okay? We'll talk about how we got the diagnosis of ARDS. ARDS is acute respiratory distress syndrome. It's an inflammatory condition. We'll talk about new or worsening respiratory symptoms, bilateral lung opacities. He's got them. You can see he's all over the place. No signs of cardiac failure, so what we need to do is get an echocardiogram. His echocardiogram showed what? Showed ejection fraction of 55%. So the echo rules out heart failure. We'll talk about how you get the official diagnosis of ARDS. So I want you to think about ARDS is that soft tissue of the lungs becomes like a brick. It becomes fibrotic like a brick. You can have elevated levels of pro-inflammatory cytokines. Remember these cytokines, it just keeps coming back, coming back. Someday we're gonna have a key to just turn these off and to save lives. We don't have that right now. Hey, guess what? Guess what's elevated? IL-6. Isn't that kind of funny how we're having this in a lot of things? Also tumor necrosis alpha and interferon gamma. All these are kind of familiar, right? Because we're seeing these as a seeing this pattern.